Good morning, everyone, and thank you for the introduction. I am a surgical pathologist, and I'm a member of the multidisciplinary team that takes care of patients with gastrointestinal stromal tumors. But I'm one of the individuals who work in the background to provide the information necessary to understand what the disease is, what is the potential prognosis and behavior of the tumor, and also offer information regarding the best forms of therapy. And to have a better understanding of my role, I'll want to take you for a small portion of the day in my life, which starts early in the morning at 7 o'clock at a tumor board where a patient is presented who complains of abdominal pain, vomiting, and evaluation has revealed anemia. We are looking at a cross-sectional CT scan of the body, and this black structure represents the lumen of the stomach. And we can see that the wall of the stomach is markedly abnormal, and the radiologist is very concerned that there is a neoplasm that has resulted in ulceration of the gastric mucosa and bleeding. The surgeons recommend that this mass needs to be removed from the patient. I, as the surgical pathologist, receive the resected portion of stomach. I dissect it, and here is the wall of the bowel, and the abnormality is this large, solid, tan white mass that has ulcerated the overlying mucosa. I carefully sample it. I have a section of the mass under the microscope, and I can see that it is composed of many cells. The cells have variable size and shapes. Some are elongate like a hot dog. These are known as spindle cells. Others are large, polyhedral, and round, and these are known as epithelioid cells. I'm looking to see how aggressive these cells potentially are, and I'm trying to identify evidence of cell division. Now, I actually do literal counts of how many divisions are occurring in certain quantities of the tumor. By the histological features of the tumor, I generate a differential diagnosis, and I am very suspicious for gastrointestinal stromal tumor. I can further prove that suspicion by doing additional studies where I can analyze the expression of markers by the tumor cells that are specific for gastrointestinal stromal tumor. And one of those important markers is known as a protein as c-KIT. And here in this immunohistochemical slide, all of the brown staining represents a positive reaction that allows me to confidently make the diagnosis of gastrointestinal stromal tumor. So the patient's physicians now know the type of neoplasm the individual has. But making a diagnosis is not providing enough information. As a pathologist, I need to provide information regarding the potential biological growth of the neoplasm. Is it going to be high or low risk with regards to threatening the life of an individual patient? So to accomplish that, I analyze where did the tumor arise. We know it is the stomach. How big is it? This particular tumor was 12 centimeters. How many cell divisions were in 5 millimeters of square surface of the tumor? And based on these three components, I can assess the risk of the tumor of having a high probability of behaving in aggressive fashion. And what does aggressive fashion mean? The patient is at risk for developing a local recurrence. The patient is at risk for developing metastatic disease within the abdominal cavity or potentially the liver. But is this enough information for the current modern treatment of gastrointestinal stromal tumors? And so the question is, what is missing? And as all of you can answer it, it is the mutational abnormality of this particular tumor. Remember, it is the mutations that are occurring within the normal cell that gives rise to the cancer. It is the type of the mutation that is going to determine what the tumor looks like under the microscope, how it is going to behave, how many cell divisions it is going to have under the microscope, and again, what kind of probability it will have to undergo metastatic disease. Remember, a mutation is any change in the DNA. The DNA contains the recipe that determines all of the molecules that our cells in our body make. And in the laboratory, we have very sophisticated equipment where we can analyze block by block the individual components of the DNA, and that is known as sequencing the molecules of the DNA. And the name of this process is next generation sequencing of the DNA. There are a variety of different types of mutations that occur in the cells that give rise to GIST. Some of the common ones are portions of the DNA are lost. These are known as deletions. So the proteins that are made may be abnormal, or the proteins aren't being made at all. Or sometimes the mutation just selectively switches one molecule for another, again, resulting in dramatic changes in the type of proteins and the impact that they have on a cell. And this is an example. Each one of these dominoes of a variety of different colors is related to another. And together, all of these dominoes or all of these genes are producing the proteins that allow our cells and all of the cells of our body to function normally. One single mutation, one single abnormal domino can result in a dramatic change in those proteins. So in this imaginary example, resulting in a type of organism that doesn't exist, or in the setting of our body, a mutation occurring in a normal cell results in the development of a cancer within the gastrointestinal tract known as gastrointestinal stromal tumor. I like to compare a mutation in a gene as the conductor of the orchestra, and all of the other individuals playing many different instruments are other genes that the conductor influences. So once the conductor is abnormal, all of the instruments or all of the other genes are functioning abnormally. And in a cell, all of these genes are producing molecules that work together, forming these complicated pathways to produce the substances that our individual cells need. And once the mutation occurs, these cell processes are abnormal. Understanding what mutation is present determines what cell signaling pathways that become abnormal. but it also identifies a target. If we know that the abnormality is here, we can potentially develop some type of molecule that will treat that abnormality and result in suppression or cure of the cancer. As you have heard, and as most of you are aware, the most common mutations in the cancer of gastrointestinal stromal tumor affect several different types of genes. And the most common genes affected, the two most common, are c-KIT, and the mutations in c-KIT account for 75 to 80% of all mutations, followed by the mutations in platelet-derived growth factor receptor that account for 10 to 15% of mutations. The mutation results in an abnormal molecule. So normally, in a cell, we have two c-KIT molecules, and they are waiting to be stimulated by binding to another protein. When the binding occurs, the molecule is activated. The mutation in GIST results in automatic binding of the two c-KIT molecules such that they are always active. They are always driving that cell to produce abnormal proteins so the cells can live longer and they can grow faster. Now, in summary of some of the major mutations in KIT and gastrointestinal stromal tumors, those that affect the KIT molecules have worse prognosis than those that affect platelet-derived growth factor. And within the individual types of mutations, some are more aggressive than others. And although that c-KIT and PGFR are the important mutations, there are a handful of mutations. Although they account for a small percent of the mutations, they are extremely important in understanding the biology of the disease and providing appropriate cures or attempted cures for the gastrointestinal stromal tumor. Once we know the mutation in the gastrointestinal stromal tumor, it allows us the opportunity to treat. But as long as there are tumor cells in the body, there is additional risk for the development of the acquisition of new mutations over time. So as these new mutations develop, it may make that gastrointestinal stromal tumor no longer susceptible to the drugs that have been developed against mutations in c-KIT. And that's one of the problems of having gastrointestinal stromal tumors to be present within the body over long periods of time, because the longer the tumor is present, the greater the probability that additional mutations that may be associated with resistance to drugs will develop. So, in summary, mutational analysis is extremely important in understanding the biology of gastrointestinal stromal tumors. And as a pathologist, recommend that all GISTs that are at least intermediate high risk should be tested to provide information to allow the medical oncologist to determine what kind of drug, what dosage, what is the prognosis of the individual tumor. Mutational analysis will identify new genetic mutations over a period of time. In those individuals who are predisposed to developing GIST and have an underlying syndrome, mutational analysis will identify those syndromes. And again, extremely important, the mutational analysis is the foundation for finding the targets of current and future therapies. And with that, I will end my discussion.
Thank you so much, Dr. Rosenberg. Phenomenal presentation, as always. I'm going to hand this off to Marcus to introduce our next speaker.
Yes, thank you, Sarah. Thank you, Dr. Rosenberg, for this fantastic presentation. So our next speaker, we have in Germany a very big cancer center called the West German Cancer Center with 2 locations in Essen and in Münster. And our next speaker is the director of the Pathology Institute of Münster, Professor Dr. Eva Wadelmann. And Eva is working with the patient community, I would say right from the start, from the very early beginning. So we have done a lot of work together during the last years here in Germany. And she is also a board member of our new organization, Sarcoma, the German Sarcoma Foundation. It's a great pleasure to have you here, Eva. Thank you very much. The floor is yours.
Yeah, thank you very much. It's my pleasure to be here, and it's also my pleasure to have listened just to Andrew Rosenberg, as he's also a very experienced and well-known pathologist in Germany. So I will try now to share my screen, and I hope that you can see what I want to show you. Can you see anything?
Yes, it's fine. Thank you.
Okay, great. So what you can see on the front page is what I want to talk about. Of course, you heard already a lot about mutation analysis. And I will now show you a little bit about the technical issues. So how do we do that? How do we get these little molecules out of the tissue, especially after we have put it into a paraffin, which makes it even more difficult to get a good quality DNA out of this. So let's just begin very simple. Normally, when we get tissue to examine, which can be either a biopsy or an operation tissue, we put it in such a wax block, which we call paraffin block. Often we also talk about FFPE, formalin fixed and paraffin embedded tissue. So it's FFPE blocks where your tumor tissue is in. So we have to cut the block, and what we then do is we stain that, and we can see under the microscope what's going on, whether this is a GIST or not, to make it simple. We count mitosis, as we heard. And if we want to do now mutation analysis, we have to take the tissue again off the slide to get the DNA out. So what we do is we put with a pencil such markers on the slide. And you can see an N for normal and a T for tissue, and we give also the tumor cell content. And then we've got such slides which are unstained, and now we have to scrape off the area where the tumor is. And this is done just by hand, as you can see here. So they scrape off the area where we have marked the tissue, and then we get the paraffin off the slide, which is very important because it hinders the DNA analysis. And at the end, we've got such a small amount of sample, which we then further process. Historically, we've done a method to do this analysis called Sanger sequencing, according to Mr. Sanger, who worked on the sequencing procedures. And what we then got were these nice looking comics where we could get the precise DNA sequence from a specific tumor. And you can see here what you are already experienced about, for example, KIT exon 9 mutation or a KIT exon 11 mutation here on the right side. And it was a very nice method to do, and it was also cheap, fast, and easy. But the problem is we could do it only exon per exon. So for this reason, we needed new methods, as mentioned already by Dr. Rosenberg, allowing us to analyze more exons in one only reaction. And so what we do now is next generation sequencing, as we heard already. And you can see a very complicated workflow here on the left side. I will not go through it into detail, but just let me tell you that by this action, we can look in a GIST and analyze all the relevant hotspots in one reaction. So this makes it easier, or we could even think it make it faster, but I will tell you in a minute that it's not faster automatically. So the pros and cons of this next generation sequencing are very simple. We need even less DNA than we needed for Sanger sequencing. So this is good to have a high sensitivity, even in a small biopsy. It's more sensitive. So even if the amount of mutant DNA in a sample is very low, we still get the mutation status. We can do numerous genes in one step. We can quantify the mutant DNA, and we can also detect minor resistant subclones. As you heard already before, under treatment, resistance can occur, and this is often due to new mutations in KIT. So this is all good, but the bad things are we can miss longer deletions. This is a technical issue. For this reason, if we have a so-called wild-type GIST after our first NGS, then we normally add a Sanger sequencing. So we go back to our historical approach, not to miss any of the longer deletions, especially in KIT exon 11, because they are very sensitive to imatinib, so it would be stupid to miss them. So this is why we also historical old samples called wild-type GIST. We always go inside and try again to do it with a more sensitive analysis and also with other alternative approaches to be sure that it's really KIT exon 11 wild-type. We need more bioinformatics. This is takes a lot of work, and so we also need now people in our department to help us with that. We have higher costs. I will come to that in a minute. And the turnaround time is longer because the procedure until you get back the result is longer than with Sanger sequencing. So these are the disadvantages. I was asked to talk about money, which is always difficult, especially in such an international audience, because you all will have different insurances, and this makes already a big difference. And in Germany, it's specifically complicated how this is built. So I tried to give you just an impression, which is absolutely not really exact, that due to the different health systems and insurances, the cost for such an NGS analysis in our country is something between 1,100 and 2,200 euros. And it also depends on whether you're in a hospital or whether you're in an ambulant praxis, practical doctors department, because this makes a difference for how it is built. Sanger sequencing is cheaper, but remember only one exon, and one exon costs 200 euros. And if you remember how many genes we now have to look at and how many exons, it can be much more expensive, so that we limit ourselves just to be not too expensive to 5 exons that we bill afterwards. It's for free, which of course you can only do in university because it's not very economic. So let's move on. Why is this approach so important to look again in older samples? I will just give you one case, an epithelioid gastric GIST. And you can see we did a Sanger sequencing. It's an older sample, and we got wild types. There was no mutation in all the hotspots we looked at. And especially in this area for the epithelioid, we expect often to have point mutations in this specific codon, which leads to primary resistance to imatinib. So it's so important to be sure that a tumor doesn't have this point mutation. So in this case, we didn't find anything at that area. Years later, the patient didn't respond well to the treatment. We repeated our analysis, but now with our novel approach with next generation sequencing. And as you can see, that in a low frequency of 11.45%, we found a mutant PDGF receptor alpha exon 18 mutation leading to D842V amino acid change. And this leads to a primary resistance to the drug. So this explains if we look back, why the patient didn't respond to the treatment. And this was a methodology problem because of the lower sensitivity of the historic Sanger sequencing. So higher sensitivity of NGS allows safer detection of relevant mutations as compared to Sanger sequencing. Now, let's move on to the non-KIT, non-PDGF receptor alpha mutant GIST, which of course make only small proportions. These are our own data from about 1,400 GIST. And you can see there is this red piece here, of about 10% of all GIST having no mutations in the classical hotspot that we know. So let's look what's about these 10%. One important issue is neurofibromatosis type 1, which is found in not in a frequent number of patients as a prerequisite to get a GIST during lifetime. And the frequency of this occurrence of GIST is about 7%, depending a little bit on where you look for. So this looks very complicated, but just remember, alternatively, compared to KIT and PDGF receptor alpha, NF1 mutations can lead to GIST. Another area where we have to look for is KRAS. Again, very rare situation that we get KRAS mutations. This small series, for example, describes some cases. In real world data, it's far below 0.1% of all GIST, so it's really rare. And BRAF. And BRAF, all these three are in the same signaling pathway or influence the same signaling pathway. NF1, BRAF, and RAS, KRAS. So interestingly, BRAF mutations, normally we know very nicely from melanoma or colorectal cancer, but as you can see also in GIST, BRAF mutations can lead to the development of a GIST or even of numerous GISTs. In our own series, the frequency was 3.9% of the wild type GIST, so of the 10%. So it's a really small number. It's below 1%. It's something like 0.1. Again, a very small group. And interestingly, we've got an immunohistochemistry that we can use to indicate without sequencing already whether that we have to suspect a mutation. It's working very nice with this antibody, but we can also do, of course, Sanger sequencing is here, NGS, or we can also do other approaches to have a fast result. And if we correlate that immunohistochemistry, at least 9 of 11 of our own cases had this positive staining for a screening approach. This is nice. It's not, you always have to prove it afterwards on the genetic level. And now we come to a very important detection in GIST, which explains the vast majority of the so-called wild-type GIST, of the non-KIT, non-PDGF receptor alpha mutant GIST. And this is this chapter here. And it looks to you rather complicated, I suppose. So I will try to make it simple, more simple. On the left side, you see a mitochondrium. These are the little guys in our cells, in all our body cells, making energy. And this is very important. And those of you who have at any time looked in biology on what the teacher told you knows that there was this citric acid cycle, also called Krebs cycle, making the energy in these mitochondria. And there are several proteins that are degraded or that are modified to get energy. And one step, and this is where we want to look now, is from succinate to fumarate. And there is an enzyme doing this, so making this change. If this enzyme, for any reasons, is not working anymore, then you get an accumulation of succinate because it cannot be transformated to fumarate. And this is what happens in a significant proportion of GIST patients. And this is shown here. The normal activation loop is that we have KIT mutation leading to activation of this, this signaling pathway. For PDGF receptor alpha, we've got an alternative route. And then we've got this action with a succinate dehydrogenase complex, and we abbreviate that SDH because the other word is, you cannot say it. So SDH complex. And this SDH complex sitting here in the wall of the mitochondrium, if this is working not anymore, then we've got a succinate accumulation, first in the cytoplasm, then moving to the nucleus and modifying the gene expression profile of the cell. And this facilitates the development of a GIST. So this was a try to explain that we have, in fact, in this case, not an activating mutation, driving, making the proliferation faster directly, but because there is a loss of something, a functioning SDH complex is not working anymore. So how can we see that under the microscope? There's again an immunohistochemical marker, which is called SDH antibody, SDHB in fact. And this is one of the 4 pieces of this complex. And if this SDHB is lost, then we don't see any staining anymore. So this is normal in the whole body. We've got SDHB, and this is negative. So if we've got a loss of SDHB, we can suspect that the SDH complex is defect. And this is very important because then we have a different biology of these tumors, and also the treatment is completely different. One interesting finding was found, in fact, in Germany by Florian Haller and his group. There is also one mechanism where the SDH complex gets a defect through some regulation processes and not through a mutation. So this is, again, a specific subgroup of GIST, and the disease belonging to that is carnine triad. I cannot go into detail because it takes too much time, but I just want to explain you that there are different mechanisms how the SDH complex can have a defect. And if we now look, how many cases are these? Then we see, oh, wow, these are in this collective from Inga-Marie Schäfer, at least 13.9%. This is a large number. And these are completely different tumors because they are young females in the gastric location. They got multifocal tumors. They've got lymph node metastasis. They got liver metastasis. And although this metastatic phenotype is occurring, often they have a very prolonged disease. So it's not so aggressive, but it's, it's still there and it's disseminating throughout the body. So if we now take that and want to make a new molecular classification, then we have to say there are on one hand these SDH competent cases. So we have SDH complex. And in this group belong the KIT and PDGF receptor alpha mutant, all these mutations here, and also some very rare fusions, so translocations in genes. It's very, very rare. But some other genes, and on the other hand, you've got the SDA deficient ones, where you've got the loss of this complex. And so there are specific syndromes, but also triad, the carnine triad, leading not only to GIST, but also to other diseases. I will jump over this because it's a very, very crowdy comic, and you can see there are some details about how these patients have different locations of tumors and so on. But to jump over to liquid biopsy, this is my last topic, because of course, everybody is very much interested in how can we monitor now the disease? How can we follow up the patients? How can we detect very early resistance and so on? So everybody hopes that we can do this by just drawing a blood sample from a patient. And I have to say that there are very promising approaches, very interesting studies about different contents that we can have in the blood. Can be either free or circulating tumor DNA, circulating tumor cells, even extracellular vesicles can be taken out of the blood. To make a long story short, although it would be so nice to do this and to have all these opportunities, there are still technical issues, limited studies, and lack of standardization. So at this time point, I have to say that we are not already in a routine procedure. It's still an issue of research, and I'm very hopeful that one day we can use that as a very good procedure, but it's not routine nowadays. And on this slide, there are different issues why this is not the gold standard yet. We have as a gold standard still the tissue sample. If we want to know, for example, is there a secondary resistance? Do I need a new mutation analysis and so on? These are the genes that are important to brief that up. So to conclude, very rare translocations and liquid biopsy is not yet a routine procedure. And with this, I want to close with a little look on Münster downtown. I can just encourage you, come to Münster, which is a very nice old city, and you will love it. And now I hope you have some questions.